My name is Kayla Wolf, and this is my project for NSG 472. My current patient safety concern would be the spread of CRE to patients on our floor. I want to prevent that because currently the ICU has a CRE infection going around, and everybody who comes from the ICU to us has to be put on contact precautions until we can rule out CRE, and we currently have about 3 or 4 patients who actively have a CRE infection on our floor. So my goal is to use the IHI model for improvement to prevent the spread of CRE to other patients on our floor who have not been to the ICU. So in viewing this presentation, I think it's important that we understand CRE infections a little bit. So in a systemic review by O'Hara, Farrell, Sahal, and Safdar, 2016, they state CRE healthcare-associated infections have been associated with a number of patient attributes, such as acute renal failure, parenteral nutrition, and previous antibiotic exposures. Treatment options for CRE organisms are typically limited, and infections are associated with more than double the risk of mortality. So as you can see, preventing these CRE infections is very important because there is not a lot of treatment options. It's very hard to treat. So if we can prevent these from occurring, the better. In preventing the spread of CRE, I am going to use the IHI model for improvement using the ACT, Plan, Study, Do. I am going to ask myself the following questions. What are we trying to accomplish that would be preventing the spread of CRE from infecting our current patients on the floor that have not been to the ICU? How will we know that the change is an improvement? Well, there will not be any more spread of CRE to those patients. What change can we make that will result in the improvement? That would be following some simple guidelines that I will go over in a couple minutes. Preventing the spread of CRE using the IHI model for improvement. First, I set an aim. In our current CRE outbreak, I would like the aim to be to prevent the spread of CRE from infecting the current patients on our floor who have not traveled to the ICU. Second, I established measures. Management will be observing staff coming out of CRE contact rooms, making sure they are observing staff washing their hands after leaving each room. Obviously, management cannot observe anything, but they will be trying to keep a close eye and making sure staff are following these measures when they can observe them. Staff will also be given a quiz on the strategies to prevent spreading CRE after an in-service. Identify changes. Staff will have a list of strategies to implement to ensure they are doing their best to prevent the spread of the infection. Fourth, test the changes. Staff will be presented on information on CRE and given a list of these strategies during an in-service. They will receive a test on these strategies at the end of the in-service to ensure their understanding of these strategies of prevention. These strategies will be posted all around the nurses' station as a reminder and on the doors and in the rooms of those with CRE infections. Management will then observe and measure how well nurses are implementing these strategies. Lastly, implement the changes. After refining the process changes through several PDSA cycles, we will be able to make these prevention strategies part of our everyday work to prevent CRE. Strategies to prevent the spread of CRE. Landry and Hurst, 2013, stated decreasing the impact of CRE requires coordinated efforts between nurses and other clinicians as well as administrators to improve patient outcomes. And on the right, you can see a picture that they included in their article on strategies that can be used to prevent the spread of CRE, which include hand hygiene before and after all patient contact, contact precautions on not only patients with known infection, but also suspected cases, which is when we rule out patients who come from the ICU who may or may not have it. And we keep them on the precautions until we know that they are not infected. Education of all healthcare personnel, minimizing the use of invasive lines, and taking care of those invasive lines per hospital policy. Patient and staff cohorting, we're going to isolate these patients and attempt to not assign nurses who are caring for infected patients to other infected patients. This is not always a possibility, but we will try our best to limit the exposure. Laboratory notification, antimicrobial stewardships, educate prescribers to match the drug to the bug, and teaching patients to take antibiotics as prescribed, the full course. And of course, CRE screening. We should be screening all of our patients at least weekly, especially those that are at-risk patients and those that are not responding to their antibiotic therapy. We need to be alert for signs of sepsis. As I stated before, information on how to prevent the spread of CRE will be presented to staff during an in-service, and staff will have the opportunity to ask questions as well as take a quiz at the end to test them on their knowledge. Then these measures will come into effect, and staff will be evaluated on how well they are following these measures, which will ultimately show if patients are becoming infected or not. Evidence from literature. Landry and Hurst 2013 states CRE has become a significant public health issue, especially for chronically ill patients with invasive devices. It's vital that nurses and other clinicians recognize cases of possible CRE infection, report suspicion promptly, engage isolation and contact precautions to assure containment, and teach other staff, patient, and family members about the significance of these measures. With the mortality rate of CRE as high as 50%, the risk to compromised patients is substantial, and nurses must be the frontline providers in taking steps to promote patient safety and infection control and to improve patient outcomes. Bitanga in Austria, 2015 state, patients who are hospitalized with devices such as suprapubic catheters, central venous catheters, and ventilators who are taking antibiotics are at highest risk for CRE infections. Residents of long-term care facilities are also at risk. Patients undergoing organ or stem cell transplantation are susceptible to infection due to neutropenia. The patients on my floor are patients who have received heart transplants or are currently waiting for transplant, which puts them in a high risk for developing CRE. And if these patients who are waiting for transplant get infected, it can affect their transplant status. Temkin, Adler, Lerner, and Carmelli 2014 stated the main route of spread is from patient to patient via contaminated hands of healthcare workers, although transmission has also been traced to contaminated endoscopes as well as sinks and drain pipes. 3 steps are required for healthcare workers to spread CRE from patient to patient. The worker must touch a patient colonized or infected with CRE, or their contaminated surroundings become temporarily contaminated with CRE, and then touch a non-colonized patient while still contaminated. This would be without changing gloves or washing hands. So it is important that we change our gloves, number one, but wash our hands before and after patient contact. The AHRQ 2014 states the new recommendations include enhancing compliance with hand hygiene, placing CRE colonized or CRE infected patients on contact isolation precautions, minimizing the use of invasive medical devices, patient and staff cohorting, i.e. designated nursing staff working with colonized or infected patients, promoting antibiotic stewardship, and screening patients with risk for CRE. The CDC recommends that in areas where CRE is endemic, healthcare facilities undertake 2 additional measures: active surveillance for CRE and the use of chlorhexidine bath or wipes.